Welcome everyone. This is Doug McCall from the International School Health Network. Pleased to welcome you to the second webinar in this series of webinars on what we're calling the new approaches to school health promotion. We'll be starting the session in a moment or two as we expect more folks to join us, but we'll begin the session on time to respect the fact that people have taken on everybody else's schedules. I'm looking forward to this session. It's part of a series of webinars that we started this week. We had an excellent session on Monday with a couple of presenters from the United States and Canada looking at the role of school nurses in school health promotion and the investments required to that type of program. And it was an excellent start to our session. I'm very pleased to be looking at the evidence today. So very pleased to welcome our presenter, Becky Langford. And Becky, if you can just click on your mic and say hello, and I'll just do a bit of background starting up.
Hello, this is Becky. Hi.
Oh, great. And so our sound is good. So I just, beginning the session, I'd like to introduce our presenter, who is Becky Langford. She is a research associate with the Decipher program in the Center of Excellence for School and Community Medicine in the University of Bristol. The Decipher program is the development and evaluation of complex interventions for public health improvement, and that focus obviously is very important for our presentation today. Becky is a medical anthropologist with an interest in combining qualitative and quantitative research methods. Her doctoral work focused on the development and evaluation of a hygiene intervention in Nepal, in India. And prior to returning to academia, Becky worked for the National Health Service in the northeast of England as a health development worker there. So very pleased to be welcoming Becky to this presentation. At the end of her presentation, we'll be opening up for questions and comments. And as I've said earlier, if you have a question or comment during Becky's remarks, please type it into the chat box, and I'll come back to it and read it out loud as we move forward. I'm also Rona Campbell, who was going to be a co-presenter with Becky, she had a last-minute change in her schedule, so was not able to join us today. But I'm sure Becky's going to be able to give us an excellent presentation of the work that she did with Rona and with several other people in the United States and in Australia. So Becky, without further ado, if you'd like to begin your remarks.
Okay, thank you very much. And I'd just like to start by thanking Doug and his organisation for inviting us to come and do this webinar. It's a great opportunity for us to be able to present the results to a wider audience and also to get your feedback. So I'm really looking forward to the discussion that will happen afterwards. So I'm going to be presenting today a kind of brief overview of the results from our recent Cochrane review that we've just published in April this year into the World Health Organization's Health Promoting Schools framework. I was going to start off by just explaining who I am and who I work for, but Doug's already explained what Decipher is. I will just add that it's a collaboration between 3 universities in the UK of Bristol, Cardiff and Swansea. And you can see that Decipher has a particular interest in complex interventions for public health improvement, but we specifically focus on children and young people. And because of that focus, we obviously see schools as a very important setting for the work that we do, given the fact that children spend a huge amount of time within that setting. So this is why we wanted to undertake this systematic review. So just a little bit of background about the Health Promoting Schools framework. This was an initiative set up by the World Health Organization in the late 1980s, and really it developed as a kind of response to the disappointing results that had been seen in prior work, which had just very much focused on kind of didactic health education approaches. This was really trying to move beyond that and see the school as an entire setting in which you could promote health, so taking very much a holistic whole school approach to promoting the health of students and teachers. And one of the principles that underpinned this idea was this intrinsic link that I've illustrated here between health and education. So one of the key drivers was recognizing that if you want children to be able to learn effectively in school, they need to be healthy in the first place. They need to be healthy enough to be able to turn up to school, but also to be in a sort of fit physical and mental state to be able to take in and process the information. But of course this relationship works also the other way around, in that the better educated you are, the better your health later in life. So it's a really mutual agenda between health and education that they were trying to capitalise on. Now, for those of you who are aware of the framework, you will probably be aware that there is no strict definition or formal description. This is very much an evolving and dynamic concept. However, when you're trying to do a systematic review of this idea, you do have to come up with some kind of definition and pin it down in some way. So this is the definition that we used for the purposes of this review. So we used a three-pronged approach. We chose this approach from looking at the literature and trying to use the most inclusive approach that we could find. So there are lots of different descriptions, but we felt that this one was the most inclusive, and that all of the other different types of descriptions could easily fall underneath these three different elements. So to be eligible for our review, interventions had to have some kind of input into the curriculum in terms of health education. There had to be some kind of change to the school's ethos or environment. So that could be changes to the physical environment in terms of the food that's provided in school, or changes to the playground to encourage physical activity. Or that could be changes to the social environment of the school. So that might be reviewing policies around health and well-being, setting up a health action group, maybe implementing a peer buddying system to address bullying, things like that. And the final element is links with families and communities, in recognition of the fact that whilst what you promote at school is important, it needs to be backed up in the wider community if it's to be effective. So that is the definition that we used for the review. Just a bit on the methods. As I said, this was a Cochrane review, so we were focusing exclusively on the most scientifically rigorous trials, so the randomized controlled trials. And because we were looking at whole school approaches, randomization occurred at the level of the school rather than the individual, so it was cluster randomized trials that we were looking at. Our participants were school-aged children between 4 to 18 years. And we were looking at the impact on both health and academic outcomes. So when I say health, I mean health in its broadest sense. So any health outcome you can think of, from obesity to mental health to physical activities to sexual health. And where possible, we tried to combine the studies using random effects meta-analyses. I don't know how familiar those of you who are listening to this are with meta-analysis, but for those of you who don't know a huge amount about it, very briefly, what we were trying to do was statistically combine all of the data from these different studies in order to be able to get a more precise estimate of how effective this is. So each individual study can be quite small and therefore have fairly low statistical power, but if you combine them in a meta-analysis, you've then got much greater amount of data, and your estimate of the effectiveness of an approach becomes a great deal more precise. So you can see here on the right-hand side, this is the flow of studies through our review. You can see we started off with a scarily high number of records to go through, which did take a very long time and was extremely tedious to do. But we eventually whittled it down to 67 studies that made it into our review. So this is just showing you where the evidence is coming from. Perhaps not surprisingly, quite a lot of it comes from North America, particularly from the United States. We also have a fair amount coming from European countries, and also a considerable number coming from Australia. Australia and New Zealand, this is a very well-known approach used out there, and they really have kind of led the way in adopting this approach. You can see there at the top, however, we had very few studies that were outside of a high-income context. So only 8 studies were conducted using this approach in low or middle-income countries. This slide shows you the range of health topics that these interventions focused on. A couple of things I'd like to point out to you on here. The first is that you can see here that actually about just over half of our studies were focusing on the kind of what we call the obesity agenda. So they were very much targeting physical activity, nutrition, or a combination of both of those. Down at the bottom then you can see we had a number of studies that we called multiple risk behaviour interventions. Those were studies which had a program that focused on a number of health outcomes in one program. So that usually was things like tobacco, alcohol, drugs, sex and violence. We then have a range of other topics that we're focused on. The one I would like to highlight, however, is the red section, which is for mental health. We only had 2 studies that specifically focused on mental health. You can see that sexual health, violence and alcohol had similar proportions. However, those topics were also included in the multiple risk behaviour intervention, so were slightly more represented. But I found it quite interesting that there were very few studies looking at mental health, given the high level of the global burden of disease related to mental health. Here are the results for the educational outcomes, and you can see for the vast majority of our studies, these evaluation studies simply weren't looking or recording any impact on educational outcomes at all. We only had 2 studies that looked at the impact on academic attainment. One found an effect and one didn't. We had 4 studies that looked at attendance, and in all of those studies there was a significant increase in attendance. And then a number of studies looked at other softer school-related outcomes, for example, measures of school climate. Okay, I'm going to now show a few of the forest plots from our meta-analyses. I will talk you through this because I know if you're not familiar with forest plots, it can be a little bit daunting to look at. On the left-hand side, highlighted in green, you'll see we've got 2 different subgroups that we included in our meta-analysis. So we divided this up according to the approach that was taken by each of these interventions. So all of these studies are looking here at improving fruit and vegetable intake. Some of these studies were just focusing on improving nutrition. The other group of studies at the bottom were focusing on improving physical activity and nutrition. So 2 different types of approaches. The red dots that you can see on the right-hand side and the black lines, those are the individual results for each study, so the point estimate and the 95% confidence intervals. But what we're really interested in for a meta-analysis is the black diamond that's at the bottom of each of those groups. That is the combined result for all of these studies. And you want that black diamond to be on one side of the vertical line or the other. And in this case, because we're wanting an increase in fruit and vegetable intake, you want it to be on the right-hand side, favouring the intervention, which is, as you can see for the nutrition group, exactly what we've got. So we did find a small increase in fruit and vegetable intake for the nutrition-only interventions, equivalent to about an extra half portion of fruit and vegetables a day in those students. At the bottom, for the physical activity and nutrition interventions, you can see that the black diamond is crossing the null line, and therefore it wasn't a statistically significant effect. This forest plot is showing you tobacco use. Again, you can see we've got 4 different subgroups being presented here. So tobacco only, multiple risk behaviour interventions, and then at the bottom, an emotional well-being intervention that was aimed at improving mental health, but to see if it had an impact on risk behaviours like tobacco use. And at the very bottom, a study by Perry, which was aimed at reducing alcohol use in students, but also measured the effect on tobacco use. Now in this case, because we want to see a reduction in tobacco use, you want the black diamonds from the meta-analyses to be on the left-hand side. And you can see that for all of these subgroups, the diamonds are on the left-hand side. However, for the emotional well-being interventions, the third one down, it actually crosses the null, so that one is not significant. However, the evidence for the top 2 groups is quite promising. There we can see the ones that were focusing specifically on tobacco reported a 23% reduction in tobacco use in the intervention students, and the multiple risk behaviour interventions reported a 16% reduction. So really quite impressive results there. This is the final one I'll show you, and then I'm going to summarise the results for all of the outcomes. So here we have alcohol use, and you can see again the 3 black diamonds. All of them are actually crossing the null, so we didn't find a statistically significant effect here. However, the middle group, the multiple risk behaviour group, you can see it's certainly in the right direction, moving towards a reduction in alcohol use in these students. However, it does just cross the null. But we found this with quite a few of our outcomes, was that although you can see we've got very small numbers of studies contributing data, so we didn't quite have enough power to be able to see whether or not this was really a statistically significant effect. However, in all of these cases, they were definitely moving in the right direction and showing quite a lot of promise. And I would just highlight the two studies at the top of that middle group by Beats and Lee. They were both trying the same intervention called positive action, and you can see that both of those actually found a statistically significant effect. So whilst overall this wasn't a significant effect, it certainly is indicating promise, and certain interventions within those groups were finding positive intervention effects. So this is just a summary of all of the outcomes. I didn't want to show you all 13 meta-analyses. I thought that would be a bit unfair on you. But just to summarize what we found in the review, we found statistically significant improvements in physical activity, physical fitness, fruit and vegetable intake, tobacco use, and reports of being bullied. We found no evidence of effect for the following outcomes: fat intake, alcohol, drug use, violence, and reports of bullying others. However, I really would like to emphasize that no evidence of effect does not mean evidence of no effect. We didn't find evidence that these interventions are not working. We simply didn't find evidence, conclusive evidence either way, and that was largely due to the fact that we had small numbers of studies contributing data. But for each of those outcomes, in all of those outcomes, we certainly found the meta-analysis diamond, the combined pooled effect, was on average moving towards favouring the intervention, even if it wasn't at this point statistically significant. And then you can see we had a final group of outcomes that we weren't able to meta-analyse because of insufficient data. So that was sexual health, hand washing, and then 4 studies that were the only studies that looked at those outcomes. So that was oral health, cycle helmet use, sun safety, and a eating disorders intervention. So that's a summary of the effectiveness overall. I'd like to stress that this is just looking at randomized controlled trial evidence, which obviously is the most scientifically rigorous, but it has its own constraints and limitations. We used that because we were doing this within a Cochrane review, and we used an incredibly conservative approach with our meta-analyses. And yet, even using a very conservative approach, we are still finding a positive intervention effect for a number of outcomes. So overall, we felt that this was actually very encouraging, and certainly taken together with the whole wealth of evidence that doesn't fall into the randomized trial format, which again is generally very positive in favour of this approach. Taken with that evidence, we felt that this was really bolstering our confidence in this intervention as being something worthwhile investing in. So that's the summary of the results. However, one of the other important things that came out of the review, and by bringing together all of this evidence, was being able to identify the things that we don't yet know and the gaps in our evidence base. So I just wanted to take a few moments to highlight that, because I think for those of us who work in these areas, this is very useful for helping us kind of point us in the right direction of where we might be needing to work next. So first of all, I think I showed you earlier the lack of educational outcome data. And I think this is a real problem with the Health Promoting Schools framework. As I mentioned at the beginning, the original idea behind this was that you improve students' health so that they can learn better and more effectively in school. However, that idea seems to have completely dropped out of the majority of these studies, and it's simply not being evaluated. And I think that is really a huge missed opportunity. Schools aren't actually there to be convenient locations for us to do health promotion work. Their agenda is to educate children, and that's their primary focus. And I think actually we need to work in a much better way with teachers to recognise the mutual agenda that we have. And I think that if we can go to very busy teachers with packed curriculum and say to them, look, we have this intervention that we think will improve health, but we also think it potentially will improve attendance or maybe concentration levels or behaviour in the classroom, then I think that teachers are probably more likely to be willing to be involved. And I think it seems fairly obvious to me that the most successful interventions are going to be the ones that that teachers and schools are really engaged with and really committed to. So I think alongside the health outcomes, looking at the impact on educational outcomes is certainly something that we ought to be considering. I also highlighted earlier that there were very few studies coming from low and middle income countries. Again, I think this is a real shame. If you think about the type of health issues that are particularly prevalent in low-income countries, so for example, high rates of infectious disease like diarrhea and pneumonia, or high rates of malnutrition, those things can have a very, very profound effect on a child's ability to learn. Firstly, in terms of whether or not they're well enough to attend school, but also in terms of malnutrition, it has a huge impact on cognitive development and that side of things. So I think potentially the health promoting schools approach could have much to offer in these countries, but at the moment this approach is not being used and evaluated, and I think that's something that we need to address. I also highlighted earlier that half of our studies were focusing on kind of the obesity agenda, and obviously whilst obesity is a pressing public health issue and something that we need to be concerned about, I think there's a need for evidence focusing on other health outcomes too, and I've already highlighted that I am particularly keen to see a greater number of interventions using this approach to tackle issues like mental health problems. One of the things that we identified from the review, which I found particularly interesting, was a broad division between the types of health topics that were focused on young children in primary and elementary schools, and the health topics that were focused on adolescents. So the physical activity, nutrition, obesity interventions, almost all of those were conducted in primary and elementary school children, whereas the risky behaviour interventions, so the tobacco, alcohol, drugs, sex, violence interventions, focused on teenagers. And when I was looking at this, I wondered whether this was really theoretically or empirically justified. There's no doubt that, you know, if we consider obesity, it's very important to set up healthy eating and physical activity patterns in children. But it's not as simple as just getting it right in younger children and then it continues on into adolescence without any problems. We know that there is a huge drop-off in physical activity rates in adolescents, and obesity certainly doesn't go away in teenagers. In fact, it tends to increase. So I think there is definitely a justification for investigations and studies looking at trying to address obesity and physical activity and nutrition in older children and teenagers. And equally, when it comes to the risky behaviour and substance use issues, whilst it seems to make sense to focus on teenagers, since that's when we tend to see these behaviours appearing, I think potentially there's an argument that maybe these should be addressed at an earlier age if we're really interested in effective prevention, and that perhaps some of these need to be addressed in elementary and primary schools. And in fact, the positive action trial that I mentioned earlier that looked very promising was doing exactly that, was focused on elementary and middle school children, and seemed to be very promising approach to take. And finally, just two other pieces of information that really were missing from the studies that we were looking at. First of all, there was a real lack of follow-up data. So the majority of these studies tended to do their final data collection at the end of the intervention. So we have no idea what happened after the intervention finished and whether or not any of the effects that were seen were then sustained over the years. And equally, out of the 67 studies, I think only 2 did a cost-effectiveness analysis. So I feel like these are very important pieces of information that we should be recording in our trials, because for policymakers, those are the 2 of the key pieces of information in terms of whether or not they're willing to invest and roll out a program. So again, I think that's something that we need to start incorporating into our evaluation studies. So I shall bring it to a close there. It's just a very brief overview of the findings from our review. Just to summarise, through our review and the meta-analysis we did, we found that the health promoting schools approach is effective for a number of health outcomes for school-aged children and looks promising for a number of others, although at the moment we need more data. And indeed we do need, there is much scope and need for further research, particularly in the areas that I have just highlighted. However, I think this need for research is often challenged by the current educational climate, and this is, I'm talking here really from a UK perspective, but I will be very interested to hear other people's views on this. Our government at the moment is very much focused, exclusively focused on improving academic attainment, and health education is seen as a distraction away from that agenda, rather than something that could potentially enhance the attainment agenda. And it feels like they're being set up in opposition to each other. So this is becoming a very difficult environment in which to work and do school-based health promotion. Okay, thank you very much for listening.
Thank you very much, Becky, for an excellent overview, and looking forward to the discussion. I hope folks noticed that I've just typed a comment or an invitation into the chat box. So if you don't have a microphone with a headset or a computer with a good microphone, please type in a question here, and we can. I'll come back and read them out loud. And maybe, Becky, as we're waiting for people to do that, we could sort of continue a bit of the conversation we had yesterday about the limitations of RCT work in particular, not so much this review, but the RCT work or the RCT method of research, and how it might not be capturing what we might want to define more specifically as a school health promotion approach, or a comprehensive approach to school health promotion. And I'm picking up on the phrase you used about needing to develop a strict definition, and wondered if this is a backward-looking review, as it has to be for research review. But if we looked ahead and tried to define a health promoting schools approach, or a comprehensive school health approach that is more in tune with the current research about ecological approaches and systematic approaches and systems-based thinking, would it be more complex and more extensive as a definition? And then how can we try to look for research that would help us measure and monitor that kind of more comprehensive approach? Do you have a comment on that sort of general point?
Yeah, I think it's a really interesting approach, and a comment. And I think there, as you've highlighted, there is this sort of tension between randomized controlled trial methodology and the kind of more flexible kind of health promotion approach that's used. I think there are ways around trying to capture some of that complexity and flexibility. There's a very good paper by Pope, I think, about, or no, maybe it's somebody Hall, about whether or not in randomized controlled trials you need to think about what you're trying to standardize. And she argues that you standardize processes rather than particular elements. So you have a particular, you allow schools to have a particular approach, and that's what you're looking at. So within that approach, within that particular type of process, schools can do a variety of different activities. So rather than, I think that's a particularly useful way of looking at randomized controlled trials. But in terms of the complexity, I think, to be perfectly honest, I think there are limits to how far randomized controlled trials can go with this very ecological approach. And I think perhaps we need to be starting to think about using more longitudinal data, and perhaps also the use of natural experiments to try and look at the impact of these types of holistic, very broad-based approaches, which I think are very difficult to try and squeeze into a randomized trial methodology.
Thank you, Becky. Still looking for comments or questions from folks, and please don't be shy. Just furthering that conversation a bit, one of the things that stuck with me over the years is I've read a report done by the World Health Organization in 1997. It was an expert committee convened by WHO to look at school health promotion, and they reported out that there was not a clear, broadly based understanding about what they called at that point health promoting schools that existed around the world. There was some folks who thought it was a multi-intervention kind of planning process. Others thought it was a set of values, and others thought it was looking for health outcomes or health behavioral outcomes. In other words, it was quite confusing. And one of the elements that is really, I think, important for us to look at is at what level is the action taken. And because of costs and because of the need to be very rigorous, RCTs often go to the school level. The cluster is the school. But in fact, the schools are part of systems. They are part of school boards or local education authorities, as well as they need to be supported by the local health authority. And of course, there needs to be a comprehensive and ongoing policy framework from the health ministry and the education ministry. Is that an element that you tried to find in your looking at the various studies? And if so, was there much that you did find?
It's certainly something that would have been included if it had been there, but we didn't find anything like that. As you say, all of these studies basically were effectively working at the school level and doing very little beyond that. Obviously, all of them had to have some kind of links to the families and communities, and in a couple of cases there were links with attempts to engage with the local councils to try and address things like improving park provision in the local nearby parks to increase physical activity, but that was about the limits of it. There certainly wasn't anything about kind of talking at the next level above in terms of health and education policy, which again I think is a problem, but I think perhaps potentially is partly because we were looking at randomized trials, and as you say, that doesn't really fit very easily and neatly into a randomized control trial approach. I wonder if other people have looked at the non-randomized literature in more detail, whether they've got examples that they could talk about.
Okay, thank you, Becky. Susan Hornby from our Intergovernmental Consortium on School Health here in Canada has just noted, and it relates to Becky's comment about the need for research on the linkages between health promotion and educational achievement, and the Joint Consortium has published an excellent paper, or partnered with Queen's University Research Group to develop a literature review on that. And it's a really good paper. I'm very pleased with it. And I know Leanne Como from Quebec is online. They've been doing some similar work trying to look at the fit between education and health in the province of Quebec. I'm also aware of the work that's underway in a couple of jurisdictions. The European Office of the WHO has just published an excellent overview of the linkages in a paper that is focused on their health goals for Europe. There's a Health 2020 document, and they have looked at how school health promotion can contribute to that document and the linkages between the two. And within the U.S., there is actually a Twitter group conversation, which I'm going to learn how to do later on today, looking at a review of the connections between health and educational achievement. So it is a very hot topic, and Becky, your review has pointed to that as an important theme to look at. So thank you, Susan, for that comment, and I would refer to people in that paper. Leanne Como from Quebec from the Institute for Public Health in Quebec has actually made another point. It seems another gap is to do with the duration of interventions, and several have lasted less than 1 year. In one case, 8 weeks. Is that something, Becky, that you addressed in your research, and is that how we can try to deal with that?
I completely agree with Leanne. I think that is definitely a big problem, and as she's right in noting that a lot of the studies were very short term. It's interesting again that there was this division in terms of the duration of interventions according to the health topic focused on. So again, the physical activity and nutrition interventions were far more likely to be of 1 year's duration or less. The ones that were looking at kind of substance use and sexual health, violence, the multiple risk behaviour interventions, they tended to run for 2, 3, 4, even more, went up to 6 years. So they were much more kind of intensive, long-term interventions. we did try and do subgroup analyses in our meta-analysis to look at whether or not longer interventions were more effective, but unfortunately at the moment we just don't have enough data. So you could see that in each intervention group in the forest plots that I was showing you, we had relatively small numbers of studies, and once you start dividing those up by intervention duration, we simply weren't able to definitively be able to say whether or not ones of longer duration were more effective, but it would certainly seem to make sense. And I think also, if we're arguing that these are truly, trying to change the whole school environment, I think in reality that is going to take longer than one school year to do and for it to bed in. So I think we do need to be seeing interventions that are more intense, that take a longer time, and that measure progress over a number of years.
Thank you, Becky. Carol McDougall has taught us how to use the technology. She's put up her hand. Carol, do you want to turn on your mic and ask a question or make a comment?
Yes, Doug, thank you so much. And I just would like to thank Becky for such a clear and articulate presentation. I have to say it has reassured me a lot, because when I first read the Cochrane review, I was a bit disappointed in the sense that I probably read it too fast, and no evidence of effect isn't the same as not evidence of no effect. So I missed that, and I was a little bit alarmed. But so it's been very reassuring to hear your explanation, because we really do believe in this model and this approach here in Canada. One of the things I wanted to ask was, well, I guess it's the reality, and I don't know how to solve this, but we wrote up a case study about an example in Canada, actually 2 examples, and in the book, Cheryl Vince Whitman's book, Case Studies in Global School Health Promotion, and it was Toronto Catholic District School Board here in the Toronto area, which I just went to their 10th year reunion, and they still have 98 schools still doing health action teams and health promotion work. And the big challenge is, how on earth can you evaluate that? Like, it's just nobody, I don't know, the resources to do some sort of evaluation of just whatever they're managing to do, because the key there is centralized board support and health unit partnerships. They have a coordinating committee of both, and they're keeping it alive year after year. And it's a shame that that kind of thing can't be studied or analyzed by someone who has expertise, like you or others. I don't know, any thoughts about how to capture some of the real life stories?
I think that's a really good question, and I'm not sure I have a clear answer. I mean, my background is in anthropology, so actually, that kind of case study approach and in-depth kind of focus on a particular project is something that really appeals to me, and I think that actually that's incredibly useful in terms of seeing how things work in reality and learning from those. And I think those kind of case studies that were reported in that book were really helpful for that, for being able to give you ideas about what kind of approaches you can use. I think we underestimate how important that kind of evidence is. In terms of, I know we live in a world where policymakers want to look at kind of hardcore scientific evidence, which is why they look to Cochrane reviews. And I will say something about the limitations of a Cochrane review in just a moment in response to your earlier comment. I think there's no reason why the types of approach and the the kind of methods that you were just talking about, the centralized board support and all of those key ingredients that seem to be so promising in that approach, there's no reason why that couldn't then be worked up into a randomized controlled trial methodology, if it felt to be needed. That we can learn from these case studies and then take the effective, what looks to be the effective elements, and then go and test that using that. But I think, I think we have to have a balance between randomized controlled trials that give us the scientific credibility that policymakers will be looking at, and also the pragmatic approach that doing research in real-world settings and understanding that you can trial something in a randomized controlled trial approach, but that doesn't necessarily mean that in the real world, when you roll it out, it will have the same kind of effect. So I think we need to be aware of the limitations of the RCT methodology. And just in terms of your first comment about feeling reassured about the results of the review, that's really encouraging to hear. And we found it actually very difficult to do this review in a Cochrane format. For those of you who are aware of the Cochrane background, it's very much set up to be an extremely useful method for looking at the effectiveness of certain types of interventions, but it's most effective for interventions that are looking at drug A versus drug B on a very specifically defined outcome. When it comes to incredibly complex interventions with multiple outcomes operating at different levels that we see in this kind of approach, it becomes very difficult to try and shoehorn it into a Cochrane approach. And in terms of writing up our results, we were very much restricted by the approach that is taken in Cochrane, where you have to be incredibly cautious about anything you say. You're not allowed to make any kind of recommendations whatsoever. So it was very frustrating for us to have to try and put that out, and we really wanted to try and emphasize in our presentations, and also in the Cochrane view, as far as we were allowed to, that actually, we've taken this very, very conservative approach, and we're still finding evidence of effectiveness. Because I think you read it, it's a very complex, very huge document, and you can get bogged down in the detail, and it's quite easy to come out and say, oh well, it doesn't look like it worked. But in fact, actually, you need to look in quite a lot of detail to be able to see that actually it does work for some of these approaches, and there's certainly a lot of promise. So in some of our other publications that are in preparation at the moment, we're now no longer under the constraints of Cochrane, and we are allowed to be a little bit more free with how we describe this. And obviously, it's still obviously based on the data. We're not going beyond the data at all. But I would just emphasise that the way in which you're allowed to write things in Cochrane is highly constrained, and that may account for why you initially read it as a fairly disappointing review.
Thanks, Becky. I actually wanted to jump in a bit too, and it's again part of our conversation from yesterday, was the limitations of RCT studies in a different way, and it's not a reflection on the review, because you have to review what was done in RCTs. But and I'm not a researcher, although I do read a lot of research. My understanding of research RCT studies is that they compare a new program, a program that's been developed. In this case, not a drug trial, which is actually a good analogy. In a drug trial, you either have the drug or you don't, and you're testing the impact of the drug. Whereas in school health promotion or other complex interventions, you're actually not comparing the intervention to a null situation. You're actually comparing it to an existing situation, which may actually have a lot of the different elements that you're trying to test in the complex intervention called health promoting schools. And I'm going back to the example I used in our conversation, Becky, about Health Canada did a trial many, many years ago in Nova Scotia, where a school health promotion strategy was developed in one school board and compared to a control school board elsewhere. And the trial had a number of elements of health promoting schools or school health promotion in it, and was testing that model against the comparison board. But unfortunately, the comparison board is in the real world, and they were doing things as well. And in fact, they ended up improving their school health program in a number of different ways that really muddied the waters. And so we're not really comparing an intervention to no intervention. We're comparing a more tightly developed and controlled intervention with a real-world situation, which actually may be maybe quite comparable, in fact, and so very small results could be understandable. Am I oversimplifying, or am I being unfair to RCT methodologies when I make that kind of a comment?
No, I think it's a fair comment to make. Certainly, in our review, yeah, you're exactly right in that we looked at what control actually meant in each of these intervention studies, and in a vast majority of cases, it just meant no change to their normal practice. Now, that doesn't mean that they weren't getting anything, because in most schools there will be something on healthy eating or smoking. So yeah, I think you're right to point that out, that actually you don't really know what your control group is, because you're not quite sure about the levels that are being implemented in each of the different control schools. And I think you're right in that these randomized trials, you wish you could do them in a kind of laboratory testing kind of approach, but actually we're doing them in the real world. And yes, the control group will change their behaviour potentially. We've just been running a hand washing trial in primary schools a few years ago, and it happened at the same time as swine flu. So whilst we were trying to run this intervention about promoting hand washing, there was this big deal about swine flu, and everyone was worried about washing their hands. So in fact, we had massive contamination between the intervention and control group. So I think you're absolutely right in that it's not clear often what you're comparing against. I mean, one would hope that if you've got a big enough randomized trial that you'd be able to, a few control schools might do something, but you'd still be able to see some kind of effect. But certainly it is potentially diluting the effectiveness. I think the other point to make is that apart from not being able to work out exactly what you're comparing it against, because it's not against nothing, it is against these pre-existing interventions which you don't necessarily know what they're included, and that's really an argument for including process evaluations, including qualitative assessments of what control actually means in those trials. I think the other thing that we are unable to talk about at the moment with these trials is not only are we unable to adequately understand the control, but we're also not able to compare the effectiveness of the health promoting schools approach explicitly with other types of approaches that have been implemented in schools and found to be more or less effective. So, some of the social influences models or other, different, curriculum-only interventions. We don't actually know if health promoting schools approach is more or less effective than those other ones, because we haven't had any trials that have pitted different types of approaches against each other. And I think that would be quite a complex and difficult trial to do. So I think, yes, I think you're right in there are lots of limitations in looking at the trial methodology.
Okay, thanks, Becky. Further questions or comments as we start to move towards finishing up the session? We're about 5 minutes away. The session is being recorded, so you can come back to look at this, and of course we'll post the slides and other related materials. But further questions or comments as we look forward here. I'm going to give people a moment to do that as I move to an invitation, and it really reflects, well, maybe just, Becky, do you want to just mention to your colleagues in this slide that I've just jumped to here? Do you want to take a moment to do that? This
is just the usual acknowledgements of obviously all of our funders, but also real acknowledgement of all of the co-authors that helped write the review. So Rona Campbell, who was supposed to be here but unfortunately wasn't able to make it, she was the PI on this, and then Dora and Haley were the excellent statisticians who helped us get through the nightmare of the meta-analysis. And then we've got colleagues from across the UK, in America, and in Australia, who are all very, very helpful. So we're very grateful to them for their input on this piece of work.
Great. And going to this slide, I hope people can see the top of it. It's one of the things we do in these webinars is try to develop some short Wikipedia-style summaries to capture our conversations, and we will be following up and adding to the text that you see on the screen here at the link that you hopefully will see on the screen. As we begin this discussion of new approaches to school health promotion, we're trying to look at the history of that movement and try to define or try to explain why we think we need to re-articulate what we mean by those words. And as I've mentioned earlier, part of the problem is that it's been a set of confusing or multiple sets of understandings about the terms, and so I think that's important to clarify and to articulate and to making it easier for us to look for stricter definitions, as Becky said. And so that's one point made in this text. The other is on an operational level, the kinds of clarifying things about multiple levels of action and those kinds of things. So that's good. And a third point made in this statement is that we really do need to think about new methodologies, new research methodologies, new monitoring and reporting methodologies that capture the multi-level complex interventions and how the processes that Becky has referred to. How do we capture those processes? How do we measure how well the interventions are being coordinated? How well do we measure whether or not they've been delivered in sufficient duration over time and whether they've been adequately supported? Those are all kinds of process kinds of things that are part of the agenda. And I'm pleased to say that we do have a discussion group on that kind of process stuff, and we do have a discussion group ongoing about how we can link better with the education system. If you go to the website that's referred to there, schoolsforall.org, you'll find those discussion groups. But I'm really pleased with the start we've had with this discussion group. We've sent out the invitation about 2 weeks ago. We have over 50 people who are following this conversation, and we're getting people joining up every day this week. We're really pleased. And we had about 20 people on this conversation, but I'm confident that those 50 folks, as well as many of our 2,500 folks, will be visiting the recording that's going to be available for this presentation, and will follow our discussions. We have about 3,000 people a month that come to that website, and most of them are going directly to the webinar section to be able to pick up on these recordings and slides. And so we're really pleased with the session today. But I would invite people to look at that text. If you can see the blue text, we'll be sending it out as a reminder. And we're going to be trying to work out a definition of school health promotion that is a little more strict, as Becky has said, and we will be adding, and I don't know if you see it on the slides, a summary of the evidence that Becky has added. It's in the middle of the page now on my screen, where we look at the research evidence. And Becky, if you wanted to maybe finish up with a comment on that text, where, and I was referring back to previous reviews. So the one done by Stuart Brown for the WHO in Europe is another example that is quite similar to your findings, with quite a similar methodology. And there are others out of the UK and around the world where we often have the results as described as being promising, but not quite conclusive or not conclusive. Is that a fair 3 or 4 word summary of what you found, and maybe give you a chance to articulate that final thought?
Yes, I think it probably is a fair comment, and it's a very deeply frustrating conclusion to come to, is that promising but not quite enough at the moment. I think we have to be realistic about what we can potentially achieve in terms of using a particular methodology to assess the effectiveness, particularly these randomized trials. We've had a lot of criticisms from statisticians looking at the meta-analyses we've done and said, oh, you've got such high levels of heterogeneity. But that's the reality of working in population-based interventions that have a high degree of complexity. And I think because of that, it is harder to find evidence of an effect. But I think having discussed this with local colleagues working at in public health in the local authority, they do look to review evidence, and they're looking for ideas, and they're looking for something that gives them some kind of confidence. So I think even when the evidence that we've got, we have got some definitive evidence saying yes, this is working, and it's certainly been promising in other in other areas, and it's been backed up by, as you say, Stuart Brown's review and others. So I think that it's frustrating that we can't have a more definitive answer, but I still think that the kind of evidence synthesis that we're doing is still useful for people. And as more studies have come through and are able to be added to our meta-analyses, I think we will probably see a greater and a much stronger effect of these types of interventions.
Excellent. Thanks very much. I'm going to finish up the session with an invitation, and those of you who have been on our webinars before, you'll know where I'm going with this. If you look at the icons underneath the word participants under your name, you'll see a little happy face, and if you pull down that menu, you'll see a little applause button, and I'm going to ask folks to join me in clapping and applaud, giving an applause to our speaker today. It was an excellent presentation, and we're very thankful for Becky to take the time at the very end of her day, at the beginning of our day in Canada and North America, and actually knowing that there's others on the line at different times of the day for others who are on the line as well. So thank you again, Becky, for this excellent presentation, and we look forward to talking about it. And I'm just looking at the comments there from Melanie. Again, that was referring to a document, and we'll post those documents on the website as well. So again, Becky, thank you very much. Thanks to folks for joining us today. Our next session will be, we have two in the works, a really excellent presentation from a trial in Mexico, where it is looking at complex interventions that will likely be in a date in early December. And looking elsewhere in the world, we're hoping to be able to announce very shortly a discussion of the methods used in Southeast Asia by high-resource countries to monitor what they're doing in school health promotion, looking at the awards accreditation system that's used in a number of countries like Hong Kong and Singapore and Taiwan and so on. And that is also going to be an interesting learning curve for us as from that very different context than Western Europe and North America. So thanks again, folks, for your participation today. If you if you can take the time to exit the meeting, I'm going to just shut off the recorder so that we don't continue.